Hi there. Welcome to another presentation from the Acute Care Ultrasound program of the Department of Adult Critical Care Medicine, at the University of Alberta, Canada. In this talk we will be discussing the IVC and why it needs to be de-emphasized as a marker for fluid responsiveness. This talk was prepared by Dr. Leon Byker, Ultrasound Fellow for 2020 to 2021. The framework for this talk is based on this review article, written by Dr. Scott Millington, an intensivist and ultrasound extraordinaire. I highly recommend reading it in its entirety. Fluid administration has been the mainstay of resuscitation for many years. There has been many attempts at finding an easy way to tell which patients will respond to additional fluid, and which will not. Sadly, most of them have been disappointing. There has been those with no meaningful predictive value, vital signs, CVP, and the physical exam. Then, there has been those with some measure of predictive value. Essentially, these see the body as a fluid-filled tank with pipes leading back to the heart, giving it its preload. The idea is to measure if the addition of more fluid will increase the left ventricular stroke volume and thus cardiac output. Preload can be increased in a few ways: passive leg raise, addition of crystalloid, or simply relying on the thoracic pump to provide changes in preload. The idea is to measure cardiac output and how it changes with increasing preload. Cardiac output measurements can be done in several ways: Swan-Ganz catheter by thermodilution, echocardiography, by measuring VTI at the left outflow tract, or changes in maximal velocity at the outflow tract. Pico catheter by pulse contour analysis, or bioreactance by measuring changes in impedance. Measuring change in cardiac output requires multiple measurements and may introduce error. Dynamic measurements, that do not rely on cardiac output estimation, are especially attractive in predicting fluid responsiveness. These include pulse pressure variation, stroke volume variation, and of course, the IVC. The IVC can be assessed as a static size measurement or as a dynamic measurement, relying on respiratory variation. It has been especially attractive due to its ease of measurement, and its early promise in the literature. The question remains, does the literature support IVC measurements, both static or dynamic, as a reliable predictor of fluid responsiveness? This is exactly what we hope to explore over the next little while. So how is the IVC scan done? A detailed description of this procedure is beyond the scope of this talk, but suffice it to say that the IVC is visualized through the abdominal wall in the right upper quadrant. Measurements can be taken in the long and short axis of the vessel. M mode is preferred to facilitate measurements of variation. Accurate and reproducible IVC measurements have obvious limitations and will be summarized on the next slide. The exact point of measurement, usually 2 cm from the caval-atrial junction, could be off. Next, measurement errors creeps in when the probe is held off axis to the IVC course. This error is more obvious when considering the IVC in the short axis, as can be seen in this cartoon. Another worrisome fact is that the inter-rater reliability of IVC measurements are not very good. Using a crude eyeball method has been shown to be very inaccurate. Mistaking the aorta for the IVC is also quite easy. Elevated work of breathing may falsely increase IVC variation. Right heart failure, on the other hand, will give the impression of a full vascular system, thus falsely altering IVC measurements. Lastly, any abdominal pathology that increases intra-abdominal pressures may falsely change the IVC diameter, resulting in inaccurate measurements. Let us now turn our attention to the evidence, and explore the IVC as a marker for fluid responsiveness. First, let us consider the evidence in spontaneously breathing patients. In our framework paper, 7 studies were identified exploring this concept. Of the 7 papers, 3 were negative and 2 had borderline results. It was concluded that IVC measurements cannot be reliably used as a marker for fluid responsiveness. What about the 2 positive studies? It was noted that in the one, patients were expected to perform an inspiratory maneuver that is hardly possible in critically ill patients, whilst the other used thoracic bioreactance as the gold standard, which is of course controversial, had late enrollment and showed poor inter-rater reliance. These positive papers were indeed questionable. I refer you to the framework paper for more detail on these. It appears then, that the evidence for IVC measurements in spontaneously breathing patients, to assess fluid responsiveness, is scant at best and should probably not be used. However, it is generally accepted that IVC variability of 25%, in the right clinical context, may be indicative of fluid responsiveness. Next, we will turn our attention to IVC measurements in ventilated patients, and focus first on the static measurement of IVC diameter. This study by Violard-Baron et al. Was a multi-center descriptive study of 540 ventilated patients. It evaluated end expiratory IVC diameter versus stroke volume by LVOT VTI. They had good inter-observer reproducibility. Passive leg raise and simultaneous transfer to semi-recumbent positioning was used as a means to increase preload. Measurements were done 1 minute later. Fluid responsiveness was defined as an increase in stroke volume of 10% or more. They found a weak but significant correlation between right atrial pressure and IVC diameter. They were unable to measure the IVC in 22%, with 71% measuring between 13 and 25. 37% were fluid responsive. 63% were not. They found overlap between the IVC diameter and fluid response, which makes these measurements lack discriminatory power. This led to the gray zone approach, setting the specificity to 80%. 2 distinct values were identified, 13 and 25 mm. Using this, they were able to differentiate fluid responsiveness in 23%, but were unable to predict any response in 77%. Essentially, by setting a sensitivity and specificity at 80%, 2 threshold values emerge, and an IVC diameter of less than 13 mm predicts fluid responsiveness, whilst an IVC greater than 25 mm excludes fluid responsiveness. 71% of patients lie between these values, and tremendous uncertainty remains. Next, we will look at IVC variability in ventilated patients. Our framework paper references 8 studies. 3 of these were negative, with the remaining 5 being small single-center studies, with variable results. This paucity of evidence indicates the dire need for trials on a much larger scale. Again, the same cohort of 540 patients that we considered earlier, were used to assess IVC variability in ventilated patients. IVC variability was compared to SVC on TE, changes in maximal velocity at the LVOT and pulse pressure variation. These were all compared to cardiac output calculations using VTI at the LVOT. Passive leg raise was the chosen method to increase the preload. Fluid responsiveness was defined as a 10% increase in cardiac output, and was measured at 60 seconds. They found that of the methods evaluated, IVC variability had the worst test characteristics. In a Bayesian analysis of the data, with pretest probability set at 50%, it was found that greater than 8% variability will increase post-test probability to 65%, whilst less than 8% variability, changes post-test probability to 39%. Using chosen thresholds for IVC variability of less than 3 and greater than 18%, a grey zone approach again emerge. With these, a clinician would give fluid for greater than 18% variability, and withhold fluid for less than 3%, but not know what to do with 53% of patients who lie between. These thresholds had a sensitivity of 74%, and a specificity of 90%. With the 53% of patients lying between the threshold, too much uncertainty exists to make IVC variability reliable in ventilated patients. The question is there evidence beyond what our framework paper refers to? In this 2016 meta-analysis, it was found that IVC diameter is moderately reliable, but that its utility, especially in spontaneously ventilated patients, is limited. In this 2013 meta-analysis, IVC variability was considered to be of great value in predicting fluid responsiveness in ventilated patients. However, the authors conceded that the studies were numerous and small, and that IVC variability would need further inquiry in larger trials. Interestingly, this 2018 systematic review and meta-analysis underscored the importance of tidal volume and PEEP when using IVC variability to predict fluid responsiveness. They found that those ventilated using a tidal volume of at least 8 cc per kilogram, at a PEEP less than 5, improved IVC variability's ability to predict fluid responsiveness. In summary, the evidence for the use of IVC measurements to predict fluid responsiveness is not the best. For non-ventilated patients, 25% variability is accepted as evidence for fluid responsiveness. For ventilated patients, static measurements of less than 13, or greater than 25 mm, are accepted as evidence for fluid responsiveness or the lack thereof. Dynamic measurement thresholds lie between greater than 18 and less than 3%. Note that the majority of patients lie between these thresholds, for both static and dynamic measurements. In general, the IVC does not seem to be the rising star it was hoped to be. It is likely to go the same way as the CVP. Ultimately, the IVC can be incorporated into patient evaluation, but should be used with the evidence and caveats in mind. Remember, the majority of patients have IVC measurements between the threshold values needed to predict fluid responsiveness. Thank you for your time. We hope you found this talk engaging and informative. Feel free to visit our website at absono. You can also follow us on Twitter at @Alberta_Sono.